Angela, you have done a lot of research into this,
Yes.
and I know that you've done stem cell therapy
Yes.
research as well. So can we talk about what the future can be based on your research?
I think, see, these are the cases when we are looking at infertility in the primary ovarian failures or even menopausal. They are 35, 38, and then they are almost attaining, and the poor ovarian reserve cases. The stem cell in gynecology in reproductive age group has in two places has a huge role. One is into the ovary, one is into the endometrium. That's what we are looking at. So in the reproductive people where the poor ovarian reserve, is there any FSH more than 10 or 12, where the ovarian output is not so good, the quality of eggs are not so good. So we do know that there are so many millions of oocytes are there inside the ovary. But over a time, we hardly use about maybe 600 eggs in the whole lifespan. What is happening to the rest of the things? They're still inside.
True.
They're not thinking of coming back. So how can we stimulate them into coming back into these people who are already underwent the ovarian failure?
Right.
So ovarian failure, like we know, prematurely can happen again because of the environmental hazards or radiation or viral infections or anything. So that's when what we do is we take out the autologous stem cell from the woman, and then we still laparoscopically into the stroma of the thing where the vascularity would be there, and the whole ovarian reserve is there. We stimulate it by giving this. So what happens with these stem cells? It forms a totipotent cell, and the autologous bone marrow cell has the same cell line as that of the ovary and the endometrium. So it stimulates that, and we do get the FSH coming down from 50, 60 to normal to 5, 6, and then we do have lots of pregnancies going on right now. And the best part of this is that we do double thing. One is stem cell, one is PRP also we utilize. So we have the growth factors also acting from PRP.
Okay.
So stem cell looks at the oocytes and everything which has gone into the hiding, and this will stimulate the growth factors which will help in the circulation, new angiogenesis of the ovary.
Okay.
So we look at double dhamaka in that we always dil mange more types. So we always want more for the woman and more thing. And then when it comes to endometrium, where there's a lot of adhesions, Asherman or thinned out endometrium, where aplasias will be there or hypoplasias are there. That's when again subendometrial region, we put lots of punctures with the thing, and then we instill the stem cell and the PRP. So endometrial lining regenerates again. So then again, bed becomes good for the pregnancy to sit there. So that's what
has
we
it
look at.
helped managing infertility, and how do you see it progressing forward?
See, let me tell you one thing. When there is no other chance, for this is the last chance, right? We just finished one 80 case study, and we have finalized that thing and all. When we have seen huge thing, only cases where a lot of Asherman grade 3 is there, or complete fibrosis where we are not able to stimulate the neoangiogenesis. That's when we did have an issue that not much of a result we could see. But in ovary, even in primary ovarian failures, we did see the volume has increased, number of cells have increased, and we have ongoing pregnancies of we have delivered 2 cases, and then we have ongoing pregnancies of almost 7 to 8 cases. So I think
there's still
still a lot way to go, but still there's a beginning which we started, so we will go.
I think that's a great way to look forward. Yeah, we know stem cells related to cancer, but this is something that we can
think of in reproductive usage.
Exactly. Okay. Wow.